An updated clinical practice guideline has been released in Australia for the diagnosis of Fetal Alcohol Spectrum Disorder, or FASD. The new guideline aims to educate and upskill clinicians and to standardise the assessment and diagnosis of FASD in Australia. Prenatal alcohol exposure can cause a range of harms to the unborn child. Alcohol readily crosses the placenta. Prenatal alcohol exposure may affect pregnancy outcomes, causing miscarriage, stillbirth, premature birth, and low birth weight. Alcohol is also known to be a teratogen. That is, it can disrupt the normal growth and development of organs and cause birth defects. Alcohol is a neurotoxin, disrupting the development of the brain and nervous system and resulting in a range of functional difficulties. Prenatal alcohol exposure may also cause fetal alcohol spectrum disorder. People with fetal alcohol spectrum disorder can have a range of challenges with their health, with physical activity, language, memory, learning, and behaviour. FASD is considered a spectrum because there is a wide variation in the type and the severity of impairments that people with FASD experience. So how many people have FASD? Well, research tells us that it's about 3% of the general population in Australia. That's potentially one child per classroom, which makes this the leading cause of non-genetic developmental disability. Many people with FASD in Australia are undiagnosed or have potentially been misdiagnosed. Indeed, families tell us that a delay in diagnosis is common. Many wait several years, and they have often seen multiple clinicians before they receive a diagnosis of FASD. Furthermore, a FASD assessment can be costly and a very time-consuming process. So why is a diagnosis of FASD important? Well, historically, some health professionals have been reluctant to consider a diagnosis, knowing that there is no diagnostic test and believing that there is a potential for stigma for both mother and child. They may believe that there are not many services and supports for people with FASD, and that the children indeed have other conditions such as attention deficit hyperactivity disorder or autism spectrum disorder rather than FASD. However, people living with FASD and their families tell us that an accurate diagnosis is essential. This is because it helps them to understand their unique challenges and strengths, as well as to access the appropriate services, financial supports, and treatments that they need to help them thrive. We know that an early diagnosis is critical to allow for early intervention that will set people up to thrive for life. Making an accurate diagnosis in a timely manner requires that we have more FASD-informed health professionals in Australia. So who can participate in a FASD assessment and make a diagnosis? Well, every clinician, whether a medical specialist such as a paediatrician, psychiatrist, obstetrician or geneticist, a psychologist or an allied health professional, a general practitioner or a midwife can contribute towards the assessment of an individual with prenatal alcohol exposure. But to do so, they need to understand what constitutes a diagnosis of FASD and then carefully record all the relevant information that is available to them in their own clinical practice or setting. They also need where to refer if they need additional assessments or help in making the diagnosis. A directory of FASD-informed clinicians and clinics is available on the FASD Hub. We understand that all health professionals approach conversations with their patients with care and sensitivity, but cultural safety must be prioritised when we're seeing patients from Aboriginal or Torres Strait Islander communities or those who are culturally and linguistically diverse. More advice on resources and how to deal with cultural safety are available on the FASD Hub. So what is the history of the guidelines for the diagnosis of FASD? In 2006, the first Australian guide to the diagnosis of FASD was released to facilitate and standardise the assessment and diagnosis of FASD in Australia, and this was updated in 2020. The new clinical practice guideline, released in 2025, is called the Australian Guidelines for Assessment and Diagnosis of Fetal Alcohol Spectrum Disorder. It has been endorsed by the National Health and Medical Research Council of Australia. So what has changed in this new guideline? Well, the guidelines have been thoroughly reviewed and updated to incorporate all new research evidence. They strengthen the voices of people living with FASD and their families, as well as Aboriginal and Torres Strait Islander people. In addition, there is more emphasis on a lifespan approach, emphasising the fact that FASD is not a condition restricted to children. For clinicians involved in assessment for FASD, there are several changes to the diagnostic criteria. As in the previous guide to diagnosis, the first criterion A, is prenatal alcohol exposure. Clinicians are given guidance about what constitutes a significant level of alcohol exposure to warrant concern or require further assessment. Clinicians are reminded that many women drink before they realise they're pregnant and then stop drinking once their pregnancy is confirmed. So it is important that they ask about alcohol use both before and after pregnancy recognition. The presence of all three sentinel facial features, the short palpable fissure, thin upper lip and smooth philtrum, can be considered indicative of prenatal alcohol exposure, even in the absence of a confirmed history of alcohol use in pregnancy. Confirmation of prenatal alcohol exposure may be obtained through various different mechanisms. Through direct maternal report of alcohol use in the index pregnancy, through report from a witness who directly observed prenatal alcohol use, and using information obtained through medical and other records, including child protection and justice records. The second criterion B, for the diagnosis of FASD, is neurodevelopmental impairment, which should be demonstrated in at least 3 domains of function. However, there have been some changes to the names of the neurodevelopmental domains. For example, cognitive impairment has been replaced by intellectual ability. Language has been replaced by communication, and academic achievement has been replaced by literacy or numeracy skills. Finally, the domain of affect regulation has been replaced by emotional and/or behavioural regulation. The domains of motor skills, memory, attention, and executive function remain. Thirdly, to meet FASD diagnostic criteria, the observed neurodevelopmental impairments must, firstly, have a significant impact on the child's functioning, meaning that they will need additional support at home and/or school, and the impairments must have their onset during the period of child development. The fifth criteria E, reinforces the need to ensure that the individual's presentation is not better attributed to another diagnosis or exposure. This means that differential diagnoses, such as genetic disorders, must be excluded and other exposures taken into account. Other exposures might include substances or medications used in pregnancy in addition to alcohol. Postnatal exposures such as brain injury or infection should also be taken into account. Adverse experiences in childhood, adolescence, or adulthood should also be documented, as should a family history of health and mental health problems, development, or intellectual disorders. Current substance use in the person being assessed, existing neurological conditions, and nutritional, metabolic, and endocrine disorders that might impact neurodevelopment should also be considered. It is important also to note that individuals with FASD may have a range of other coexisting diagnoses. Because alcohol is known to be a teratogen and to be toxic to the developing brain and nervous system, it is important that clinicians document the presence of any physical features that could be caused by prenatal alcohol exposure. These include the 3 sentinel facial features and other facial dysmorphology, head circumference, weight and length at birth, and weight and height postnatally. The relevant measurements should be taken and the percentile or standard deviation should be recorded. Clinicians should also record significant clinical symptoms, neurological conditions, birth defects, and diagnoses such as those that fulfill DSM-5 criteria, including ADHD, ASD, and mental health conditions. As with any diagnosis, when assessing an individual for FASD, clinicians should use their clinical judgment regarding the most appropriate assessment tool and the interpretation of test results. Finally, children and individuals who have confirmed prenatal alcohol exposure but fail to meet the diagnostic criteria for FASD may be considered at risk of FASD and may require subsequent assessment as they get older. We encourage you to continue to report confirmed cases of FASD to the Australian Paediatric Surveillance Unit and the Fetal Alcohol Spectrum Disorder Australian Registry, which are supported by the Australian Government. More resources on the Australian guidelines can be found on the FASD Hub Australia. Notices of training and e-learning opportunities for clinicians in the use of the Australian guideline will also be posted on the Hub.